Thanks everyone, and welcome to the Society of Thoracic Surgeons, the General Thoracic Surgery Database monthly webinar. Today is Wednesday, January the 8th, 2025. So I hope everyone had a happy new year and a great holiday season, and I hope you're getting back into the swing of things. We're slowly getting back into the swing of things here at STS. So again, hope you all had a great new year. All right, so introduction just really quickly. On the call with me today from the STS side, it's myself and Paul Meehan, Nancy Honeycutt, Carol Crone, Emily Conrad, and then from our core group, we have Katie Lothrop joining, and then also we have Ruth Raleigh, our GTSD clinical consultant. On today's agenda, just I'll provide some STS updates, and then I'll turn things over to Ruth, and we're gonna get back a little bit, go back to the basics just a little bit, based on the questions that we've been getting. Thought maybe we would just kind of go back to our little basics and just to kick off the new year and answer any questions. If you do have questions on today's presentation, please be sure to put your question in using the Q&A function. We also have the raise hand function enabled, so if you'd like to just raise your hand and ask your question, obviously we welcome you to do that. We'd love to hear your voice. Just make sure that your microphone is enabled on your end. All right, so next, let's go ahead and kick things off for today's presentation. For our STS updates, that training manual will be posted. Hopefully, marketing will get it posted by the end of the day today. We didn't have any December updates, so just please know that that the January training manual will be posted by the end of the day if marketing can get that uploaded for us. If not, it'll be posted definitely by tomorrow. Our 2025 harvest schedule, our harvest dates are posted on the STS website, but also our spring 25 harvest close date is scheduled for March the 7th. And just a reminder that the spring 25 will include the reporting period from January 1, 2022 through December 31st of 2024. Our fall 25 harvest close date is scheduled for September the 5th and will include surgery dates of July 1, 2022 through June 30th of 2025. Public reporting update. Our next data refresh is scheduled for this month, actually. It's expected to occur next week. We will send an official announcement to our sites and to our sites once the website is updated. That announcement will go to the data managers and surgeons as well. And just a reminder that this public reporting data refresh will include the primary lung cancer resection composite, and that is replacing the lobectomy composite. So public reporting will include the primary lung cancer resection composite and the esophagectomy composites. If you have any questions about public reporting, just please reach out to us via publicreporting@sts.org. Additional STS updates. While we were out, or while I was out specifically on vacation for the holiday, the calculation for the minimally invasive lung cancer resection for clinical stage 1 lung cancer was updated. That lung cancer resection, the STS NIS compare button was reactivated on the 23rd. We did send an email out to the participants, as well as that notification was posted within the IQVIA platform. So just a reminder for everyone that the update to the calculation, unfortunately, when the report initially came out, we discovered that the calculation was only looking at robotic surgeries or robotic procedures, and not just robotic procedures for the sleeve lobectomies. So we had to get that calculation updated. The updated calculation is included in the analysis overview. So if you have not gone back out to look at those reports, that STS NIS compare button is now reactivated. So you should be able to go back and check out your minimally invasive numbers. Also, a reminder, speaking of the overview, an updated analysis overview was posted back in November. So just be sure that you are looking and referring to the current version of that analysis overview. You'll see it dated 11/22/2024. So if you have any questions, just please reach out. The updated analysis overview, again, the difference between the previous version and that updated version is we updated that NIS calculation. I added the elective procedures to the inclusion criteria, added the lung ESOPH cancer variables equals yes to the inclusion criteria for the composite. Also, I added the COVID positive records with surgery dates of July 1 through December 31, 2024 to the exclusion criteria, and then also added reoperations to the exclusion criteria. Again, all that information is in that overview. If you have any questions about those updates, just please reach out to us via the help desk and we'll get those answered for you. Speaking of the help desk, again, any report related questions, please reach out to the help desk at STSDB_helpdesk@sts.org. When you reach out to the help desk, first things first, just please refer to that analysis overview because 9 times out of 10, well, I'd say about half the questions can be, your answers are, can be found in that analysis overview. If you're not seeing an answer to your question in the overview, when you do reach out to the help desk, please, just a reminder to please include your participant ID. Please indicate which reporting time period, which report you're looking at. Are you referring to the spring 24 report? Are you referring to the fall 24 report? If you could just reiterate which reporting period you're referring to. And then as always, screenshots are super, super, super helpful. Just keep that in mind when you are submitting questions to the help desk. All right. Next, AQO info. I know I've gotten a lot of emails regarding information for AQO 2025. Those details will be coming soon, I promise you. As of right now, I know our meetings team is continuing to work and finalize the contract for AQO 2025, and then unfortunately we can't announce that information until that contract is finalized. So we are hoping to announce details at the annual meeting this year. So hopefully within the next couple of weeks, we will have all of the AQO 2025 details for you. I've also gotten a few questions about some of the AQO content from last year, from 2024. Just a reminder that AQO content is now located in the STS Learning Center, and it will be available until AQO 2025. And to access that content, you'll just sign into the Learning Center and just use your login information that you use to register for the conference. Your name will be listed in the upper right-hand corner of the site. If you do not know your login credentials, you should contact Member Services via membership@sts.org. And then on the slides here, I've included a link to the AQO meeting content on the STS Learning Center. I'll be honest, I had a little trouble locating it myself, but I had to reach out to Emily. I was like, help, can you give me a link? So here's the link for the AQO meeting content on the STS Learning Center, as well as a link to the Hot Topics webinars. All right. Once you log into the STS Learning Center, I provided Emily was kind enough to give me this information so I could share with you all. Once you are signed in, all the sessions for AQO, as you see here, will be listed as in progress or enrolled in the status column. So you'll see this information here. And then next, when you click on one of those session titles, so click on one of the session titles here, and then next you would click on the Start Activity button to access the recording and any of those related slides or handouts. So if you have any questions regarding accessing the AQO content, you can reach out to us directly. Emily, would you prefer that they just reach out to you directly for the AQO if they have any issues? Okay.
Sure.
So yeah, if you could have any questions about accessing the content, just reach out to Emily and she can help you with that. All right, that's all that I have from the STS side of things. I'm going to turn things over to Ruth now so she can address our educational content and answer any questions that you guys have.
Okay, thanks, Leanne.
No problem.
If you want to go to the next slide. So like Leanne said, we're going to take it back to the basics a little bit here. We've got a lot of new data managers that have joined us, which is fantastic. We're excited to have all of you. Welcome. And so we just wanted to start off talking about how do we know what cases are required for inclusion. So there's a section in the training manual that walks through this a little bit as well, but I put it in just a couple of slides, hoping that's helpful. You are required, if you participate in the registry, to include all new therapeutic lung resections and all new therapeutic esophagectomies. So now we're going to talk a little bit about what that means. So how do I know if you have a case that's lung or esophageal cancer? You're going to want to start by looking at your pathology report before you begin abstracting. If a case isn't staged with lung or esophageal cancer staging systems, then it's unlikely that you have a new therapeutic lung or esophageal cancer case, and you probably aren't going to need to abstract that. I did put a link in here to I think an article that sort of nicely explains the eighth edition of TNM staging for lung cancer. It's got a bunch of reference charts that you can print off. I know that Katie has shared some references in the past. There's some references in the training manual as well that are really helpful as you start familiarizing yourself with the world of oncology. I think a lot of the data managers for GTSD come from the world of surgery, and it's a pretty it's a lot of work to learn cancer when you're coming from a surgical background. So give yourself some grace and really use these references that are available in on the training manual and in other places. And you can always go back to and look at other old um, webinars that are available on the STS website as well. Is another great resource. Anyways, I digress. So look at your path report, figure out if you have a lung or esophageal cancer case is where you're going to want to start. Okay, if you want to go to the next slide. What does new mean? So the intent was to abstract new cancer cases, not recurrent cancer cases, just so that we really have an apples to apple comparison of patients that are being analyzed for therapeutic lung resection and esophagectomy. So new cancers are those that have not previously been definitively treated in some other way. Prior definitive treatments can be chemotherapy, radiation therapy, and or a prior surgical resection for the same disease. The one of the ways that you'll know that you have the same disease is if hopefully your surgeon nicely outlines this for you in their notes. Another good point of reference is, again, your pathology report. So when you're looking at your pathology report for this resection and you see a resection that occurred a year ago with the exact same pathology type, that's a clue to you that you probably need to dig into things a little bit more to understand whether you have recurrent disease or new disease. But again, communicate with your surgeons, let them know if you're having a hard time figuring out if things are new or recurrent disease, and ask them where they think you should look for those clues in the way that they write their notes, or either their pre-op histories or their operative notes. At times, you're just not going to be able to tell, and all you're going to be able to do is go back and ask your surgeon about a specific case, and that's totally fine. This is their data. They want to help you abstract cases as accurately as possible, so don't be afraid to reach out to your surgeons directly. Next slide, please. So here's some pertinent FAQs for how to identify new therapeutic lung resections. They're linked to sequence 1510 in the training manual. All of these are available for you in that resource. We're going to talk through a couple of these just in case it sort of stirs up any questions that any of you may have. I'd love to talk through any questions or clarify where I can. So the first FAQ that was in March of 2022, it says, in the case where a therapeutic lung resection is performed for recurrent lung cancer, code no to sequence 1510. The intent of sequence 1510 is to capture data on new primary lung cancer resections. So when you code no to 1510, it's not going to open up the entire lung cancer section for you. I think part of where new data managers get confused then is, if I'm saying no to 1510, am I required to enter the case at all? And the answer to that is no. If you don't have a new lung cancer case, you're not required to enter the case. The only reason that there is an option to say no to 1510 is because some sites still enter every case that their surgeons perform, which is their site preference, and it's totally fine. But this is how the STS supports sites that want to go that route. So if you're saying no to 1510, you wouldn't have to enter the case. The next FAQ talks about surgical resections of lung cancer previously treated with SBRT or CyberKnife are not new lung cancer resections. The lung resection is considered sort of a salvage procedure in that instance. The SBRT or CyberKnife treatment was not ultimately successful, and the patient has recurrent disease. Then next FAQ, lobectomy after prior same lobe segmentectomy for recurrent lung cancer is not new. Code no. For example, code no to 1510 for a left lower lobe lobectomy in 2022 for recurrent lung cancer that was resected via left lower lobe segmentectomy in 2020. Now, it's quite possible that you have a new lung cancer in the left lower lobe that requires resection in 2022. So you can't automatically assume that if you have a sublobar resection, that any subsequent resection is for recurrent disease and not required for entry. You really have to dig into your pathology reports, your notes, and think about the overall clinical picture for the patient. Let's see. I'm not going to go through all of these. I will cover again the July 2022 FAQ. If a new primary lung cancer is therapeutically resected, it must be captured. For example, patient had pneumonectomy for recurrent infections. On final pathology, the patient had adenocarcinoma. We said that that case would be required for entry. If you go back a couple of webinars, we talked about incidentally resected lung cancers, and I think we covered this at AQO as well. And this is part of what guided that response. So we do at this time collect all therapeutic lung resections, even if the intent going into the OR was maybe not necessarily to do a therapeutic lung resection for a new cancer. And the rest of these I'll just leave out there. They'll be in the slide deck. If you have any follow-up questions to any of these FAQs, of course, please always feel free to reach out or put your question in the chat right now and we can go through that. I'm sorry, the Q&A. Put your question in the Q&A and we can go through those. If you want to go to the next slide. These are just sort of the similar FAQs for the esophageal resection sequence, which is 1530, where it talks about that the intent is to only capture new primary esophageal cancer resections. Something that's unique to esophageal cancer is that September 2022 clarification. Esophageal cancers that have previously been resected via EMR, which is endoscopic mucosal resection, that are subsequently followed by esophagectomy are indeed to be captured as new primary esophageal cancer resections. That happens with some frequency, so definitely something that if your site is doing esophagectomy, you'd want to sort of tuck into the back of your mind. And I think we can go to the next slide. Again, if you have any questions about any of the rest of these, please feel free to use the Q&A or send me a follow-up email. So what's the next step? After you know that you have a new therapeutic cancer case to abstract, what do you do? So I recommend that you follow the same pattern for the abstraction of every case. Some data managers like to abstract the data collection form sort of in a top to bottom order. Some people go out of sequence of the data collection form just based on what information that they can find in each resource that they access, and that's totally fine. But especially when you're starting out, it's really helpful to sort of consistently abstract in a specific order. I would create a source document for where you're finding all specific pieces of information. If you get lucky and win the lottery tomorrow, you would want to have a resource available for whoever gets to take over your job the next day on how you were abstracting, where you were finding pieces of information so that they can easily start abstracting while you're off in the Caribbean. Some common trouble spots that I think particularly new data managers struggle with are clinical staging, PFT information, substance use screening, and then absence of mortality, readmission status information. So we're going to talk about the common trouble spots briefly. If you want to go to the next slide, we're going to start with clinical staging. So clinical staging is a series of tests, essentially, where when your surgeon is evaluating a patient for a potential lung cancer resection, they will run their patients through a battery of tests. So very commonly, if my surgeon sees a patient who has a suspicious lung nodule, what they're going to do is, presumably this is located on a CT scan already, they're going to order the PET scan. If the patient meets criteria, they're going to do some sort of invasive mediastinal staging. If they think it merits, they will do a biopsy of the mass itself. Prior to surgical resection, sometimes they just take the patient straight to surgery without doing a biopsy of the mass. All of this workup is considered clinical staging. You can have clinical staging completed only in the form of imaging without any sort of biopsy, and your patient still had clinical staging. It's very rare that your surgeon would take a patient to the OR for a planned therapeutic lung resection without doing any sort of clinical staging. There's usually at least imaging studies out there for you to reference. The only exception to that that I can think of is the previously referenced incidental therapeutic resection, but those occur with very low frequency. There's a link on this page if you want to read more about clinical staging. I highly recommend that link. And also there's lots of information in the training manual and AQL presentations that are really lovely on the topic as well. If you want to go to the next slide. I think I already talked about this. So I guess the only thing that I'll add on when clinical staging occurs is that it can sometimes happen twice. So sometimes what will happen is that your patient will have clinical staging completed, and then they'll have some form of treatment, and then there'll be more staging will occur before the patient has whatever the subsequent treatment is. There's very clear directions in the training manual about which images, for example, should be used for largest tumor size. So if your patient has imaging and then chemotherapy radiation and then is imaged again, you're going to use the largest tumor size from the imaging that occurs before the initial treatment. So again, there's a link on this slide that I think is helpful for you to reference as well if you want to do some additional research. I'm going to go to the next slide. These are just some of the various components of clinical staging. Notably, if you want to go to the next slide, Leanne. Oh, I thought I had it on the side, sorry. Notably, in the training manual for this version, there's not a way to capture needle biopsies of the mass itself, which for people who've been abstracting for a while, think it's a little bit weird because the previous version had it. I think if you're new to abstracting, it's also still weird because you feel like you're missing a piece of the puzzle, but it's okay. It's not there. Don't worry about it. This is just some FAQs pulled from the training manual regarding sequence 1600, which is clinical staging. Again, this is almost always going to be coded as yes if your surgeon is taking the patient to the OR for a lung resection, because surgeons want to have an idea of what stage their patient is before operating. Surgical treatment is only appropriate for patients with certain stages of cancer. And so that's why they really need to know this information in advance. If your surgeon documents the clinical stage in their pre-op H&P or at the top of their op note, I hope that they do because it's very helpful to you. If they're doing that and you disagree, please clarify with your surgeon to just confirm that you have the correct clinical staging information to abstract. There's a lot of nuance that goes into clinical staging. You want to go to the next slide? Oh, here we go. This is what I was thinking was the next slide. So sequence 1620 clinical staging methods. Again, you'll notice that biopsy of the mass itself is not accounted for, and that's intentional. Okay, if you want to go ahead to the next one. So another thing that some newer data managers have gotten hung up on is that for sequence 1810, where you abstract the clinical stage of your tumor, TX and T0 are not options, which is intentional because if your surgeon doesn't believe that the patient has lung cancer, it's unlikely that they would take them to the OR. So it sort of is just sort of a logical, I guess, check and balance. I think another thing that newer data managers have struggled with is the expectation that they'll see the clinical T stage explicitly documented on a CT or PET report. Your radiologist will not assign clinical staging to your cancer cases. You may find clinical stage documented, again, in your surgeon's pre-op H&P or on the op note. Another place you might find it is in tumor board notes if you have access to your tumor board notes, or alternatively, if your patient sees an oncologist prior to their surgery. Oncology is usually very good about documenting clinical stage as well. So there's some different places that I would look for that information, but I don't think I've ever seen it documented in a radiology report. If you want to go to the next slide, we're going to move on to the next sort of common sequence that people struggle with, which is PFTs. What does the training manual say about, so PFTs measure your patient's lung function. I think, as most of you know, the STS collects two specific components of that test, FEV1 and DLCO. FEV1 marks the degree of lung obstruction that your patient has. We are instructed in the training manual to indicate the FEV1 percent predicted from the most recent pulmonary function test prior to the procedure. The results have to be obtained within the 12 months prior to surgery. If they're older than that, then you would say no, that your patient does not have PFTs. And then you're going to choose the highest value reported for percent predicted, whether or not a bronchodilator was used. I went through several examples of this in a previous webinar and also at AQO. So I would, if you're struggling with this, I would urge you to reference those previous presentations or reach out to me and I can help you out with your PFT reports. The next slide talks about DLCO. For DLCO, you're going to want to choose the lowest percent predicted, unadjusted, uncorrected for hemoglobin DLCO. If you want to go to the next slide. Another place where people struggle is the substance use screening sequence, which is complicated. We covered this one extensively in November, so I'm not going to rehash it. But please continue to send me questions if you're struggling with substance use screening, that sequence. I'm happy to help you out. Next slide. Absence of mortality readmission. So this statement is in the training manual, and I just wanted to make sure that if there are any questions about what this meant, that people had an opportunity to ask questions. So absence of readmission and or mortality cannot be inferred by the absence of documentation. So if your surgeons are seeing a patient at 2 weeks and there's no note in your EHR prior to 30 days, including EHRs that allow for access to other EHRs. So like a lot of people have Epic Care everywhere. You have to have a process in place whereby you're verifying that no readmission or death occurred. So I think the one that's a little bit harder to nail down is readmission. Death is a little bit easier in the sense that if you look in Care Everywhere and your patient was seen, or if you look in your EHR and your patient went to the primary care doctor, it's very clear that they're still alive, and that's great. You can check that box. Readmission's a little bit slipperier because just because your patient was seen at a urgent care doesn't necessarily mean that they weren't readmitted somewhere else. So you really need clear documentation that your patient wasn't readmitted. So you may have to work with your surgeon's office in order to obtain this information or figure out, put some sort of a process in place to make sure that you really have good support for this in the event that you are audited. And I think that's the end of my
Yeah.
slides.
Yes, thank you. I just wanted to go back. I say we have some questions coming in, but before we go tackle these questions, I wanted to clarify one thing because Katie actually caught something. I'm trying to get to some here. I'm gonna have to angry school. Sorry, guys. Um, I wanted to go back and correct something here. In my STS updates for in the updated analysis overview, I have this added COVID positive records with surgery date July 1 through December 31, 2024. I have no earthly idea where I got that date from. So that date should be July 1, 2021 through December 31, 2024. So I'll get this corrected and updated and for the when the slides are posted. But just to clarify, the COVID exclusions are only for COVID positive cases with OR dates up through December 31, 2021. Beginning January 1, 2022, if there are COVID positive cases, those with the surgery date January 1, 2022 forward, any COVID positive case is included in analysis. And of course, all of that information is laid out in the analysis overview as well. So just to clarify, this should stay July 1 through December 31, 2024. I'm sorry, 2021. I need to go back on vacation. So sorry for the confusion there. All right, so we had a couple of questions. Let's go ahead and tackle our first question from Nancy. When will we know if our request will be in the new version? Nancy, we're in the process of the upgrade now. It's not finalized. Hope to have it finalized by, I'm hoping, April, within the next few months. So if you could just email me what your suggestions were, and I can let you know, if they were included in the new version. But as of right now, nothing's been finalized. So we'll let you know as soon as possible. But again, hopefully I'll have everything finalized by April-ish. That's if the surgeons cooperate with me. When can we expect the fall 24 harvest composite quality rating summary to be updated on IQVIA? I thought that was updated and out there. If it's not out there, hold on, let me check. But I thought that was available. Yeah, hold on, see. So the fall 24 harvest composite quality rating summary is available out in the IQVIA platform. It's just down here at the very bottom. All right. Let's see, Nancy, can you show us some of the things you were explaining so we can know where, I think you're referring to the analysis overview when I was walking through that, Nancy. But yes, so some of the information that I was referring to, like the updates, I can pull it over. I don't know what's going on. Yeah, so for the updates in the analysis overview, I was referring to here, hold on. But again, the COVID information that I just recovered, just discussed, is located here. For the updates to the overview that I was referring to, is referring to the updates to the inclusion exclusion criteria for the composites, specifically referring to here, lung cancer is yes, patient still in hospital, reoperations, COVID positive records here. So those updates were just in the inclusion and exclusion criteria for each of the composites, for the resection composite, as well as for the esophagectomy composite, the inclusion and exclusion criteria. Also the updated NIS calculation is located here. So the updated calculation here, we had to clarify specifically 2530, which is the sleeve lobectomy and robotic. So we only wanted to include the robotic lobes. here. So again, that calculation was updated for the number of patients for STS and then for the number of for STS as well as the participant sample. So those were the updates that I was referring to there. I think that's what you were speaking about. Our next question from Michelle, how do the volumes here relate to the volumes in the cancer registry? I don't know, Ruth,
I
do
think
you?
your tumor registrars probably can get pretty close to creating the same patient list for you that you create by reviewing your OR logs and then sort of marching through the steps of the process. I'll be honest, I've never had my tumor registrars try to do that work. I don't know if Katie or anyone else that's on the call has tried to have that done before, but you're not going to have like the tumor registrars are going to have all lung cancer cases as their starting point, and then they're going to be able to tell you which patients have had surgery, and then they should be able to tell you which patients um, had recurrent disease versus new disease, I think. But just like every registry, they have very specific definitions for each piece of data that they abstract. And sometimes there's little differences between the way that STS captures something and the way that the tumor registrars are directed to capture something. So I guess long and short, I don't know, but I think they could probably get close.
Thanks, Ruth. Um, Here's a suggestion, Ruth, for future webinar. Can we add how to count lymph nodes on path report, fragments, potential lymph node, partial lymph node listed on the path report?
Yeah, I'll do that for the next webinar. Thanks for the suggestion. I love
Yes.
suggestions. If anyone else
Yeah,
has
we love.
suggestions, send it along.
Yes, we love suggestions, please. If you have ideas on what you would like for future webinars, please email myself or Ruth. We welcome the suggestions. We want to make sure we give you guys education on what you're needing. All right, clinical staging. No stage in the imaging. Do we stage it based on the results, size, and etc.?
Um, Yes, so there's not going to be a clinical stage noted in your imaging. If it's not in your surgeon's note or elsewhere in the record, oncology, et cetera, then you're going to base it on the results of all of the clinical staging that occurred. Remember, it's not necessarily going to be just imaging, so you're going to have to look at your CT, your PET, any invasive mediastinal staging that was done, um, and then any, I guess, tumor biopsy that was done. Sometimes they'll biopsy a lesion, seeing if there's you know, uh, like a contralateral, whatever, like met or something that would upstage the patient. And so you would include that information as well. So you would need to put all of those things together to get your clinical stage. The training manual does a pretty good job of walking you through, like if according to the training manual, you would say that this, your patient has nodal disease based on PET, but they do invasive mediastinal staging and it's negative, like how do you manage that? That's all outlined in the training manual for you, but yeah, you'd have to come up with it on your own if it's not in your notes. But again, I would have a conversation with your surgeons. This is their data. They want it to be accurate. Ask them if there's any way they can include this in their notes.
Oh, sorry, I was on mute. Sorry about that. So you're talking to
Okay.
myself.
I didn't know if I was supposed to read the next question or not.
Sorry about that. Our next question from Corey. So a patient has two separate tumors in different lobes of the right lung. Favored two primaries. Does this need two separate case entries?
Not if both were resected in the same trip to the OR. So your trip to the OR is going to be one data collection form. So this gets a little bit tricky when you have more than one primary because then the question is always, which pathology do you abstract in the pathological section, et cetera. And there's guidance on how to do that in the training manual. I can include some slides on that in the next webinar would probably be the most helpful, but each trip to the OR is an individual data collection form, not each. tumor resected if multiple were done in the same trip.
Awesome, thank you. Heather, can I go back to the what does new mean slide? Yes, ma'am. I think that's Heather. Yeah. There you go. There's that slide for you. Yep. Let us know if you have any questions about that, Heather. I'll leave it there for a bit if you want to take a screenshot or whatnot. A question from Allison. If there is a MyChart message that the patient has COVID and it's within 30 days post-op, can we code yes to the patient having COVID, or does there have to be explicit provider documentation?
I don't recall. There's something specific in the training manual about this. Can you pull that up?
Yeah, hold on. I thought I had the training manual up. I do not. Sorry, everyone. While I'm looking for this, here's the next, let's tackle the next question while I pull up the COVID. Is it okay to code no readmission if patient sees doctor after the 30-day window and note says they've been doing well? No notation of readmission.
Yeah, that's fine. I would talk to your surgeon about maybe being a little bit more specific in their communication, but presumably no complications or whatever it is that they're writing in their note is fine.
All right, and let's go back to the COVID question. Let's see. What was the COVID question? Let's see here. Sorry, I think is it okay to code no readmission? No, that's right. Where's my COVID question go? Okay, is there a MyChart? The patient had COVID and is within 30 days of post-op. Can we code yes to the patient having COVID? Or does this have to be explicit provider documentation? I don't think there has to be. Provider's documentation of a positive COVID test is sufficient to code yes. Lab results or chart are not required. I don't know.
Sorry, I'm looking at it.
Yeah, no, you're fine.
Um, so the provider didn't make a note. It's like a note from the patient. Sorry, I have to go back to the question.
Yeah, it says
there
there's
to
a MyChart message that the patient has COVID.
Katie, I think my recollection is this is that we excluded home COVID testing, but I'd have to go back to my notes and I can certainly clarify it in the training manual in February.
Yeah, we did,
Sorry.
but then we started allowing them.
Yeah.
But I
Oh,
don't
did we?
see, for whatever reason, I don't see that noted here in what Leanne has pulled up on the screen.
Yeah.
So, I mean, if there was a note in my chart saying that the patient had a test and it was positive, then I would mark it positive. To me, it being documented, because that's how I see it a lot of the time anyway, is that the patients are, calling in, emailing, sending something in via my chart saying that they had a positive test, and that's the only way it's documented. So the
Okay.
surgeon's not going, or, the doctor's not necessarily going to leave a note saying that the patient called in and said they had a
Right.
positive home test. It might just be a note from the patient. So I would mark that as positive.
Okay. And I can update it for February.
Yeah. Then is it just COVID positive during admission with surgery and not COVID after surgery admission or prior to surgery admission? So
I think
yeah,
it's within 30 days. There's like different options you can pick.
there's 30 options. Yeah. So we have prior to hospitalization for this surgery, yes, in hospital prior to surgery, yes, in hospital after surgery, or yes, after discharge within 30 days of surgery. So let's see, Beth, there is a new version in progress. Yes. What is the expected release date? So yes, we are in the process of doing an upgrade for GTSD. It's not a major upgrade. but we are in the process of doing an upgrade. The expected go live date is January 1, 2026. If everything goes well, according to my timeline, and everyone sticks to my timeline. We would hope to have everything finalized by, if, go live January 1, 2026, everything would go, specs would go to the vendors July 1, 2025. Again, so if everyone sticks to my timeline and cooperates with me. So we hope that's what's happening. That is my plan. That is my goal. Another question: in a future webinar, can you summarize the new risk model? So we have done some webinars in the past, within the past couple of months, about the new risk model. And Dr. Cedar actually presented it, and I don't know if you attended AQO. Dr. Cedar also provided a presentation on the updated risk models or revised risk models. But I'm happy to, I'll send you, if you shoot me an email directly to Lee. What's my email address here at STS? ljones@sts ljones@sts.org. I will send you a link to that specific webinar. Okie dokie. All right, is there anything else while we are waiting? I did have one other, let me see, let me get to this, to the slides here. I don't want to angry scroll and make you all go crazy. So our next, our upcoming monthly webinars are, so you can add to your calendar, our next monthly webinars, February the 12th, followed by March the 12th, and then April the 9th. So again, just mark your calendars for February 12th, March 12th, and April the 9th for our next upcoming webinars. If I receive a response in Outlook and it's my spam, which deletes. Okay. I think I don't know if you were communicating with Ruth. But if you haven't, yeah, I think Ruth is following up with you directly.
Oh, I'll
you will?
I'll type you a message here real quick.
Okay. Perfect. Thank you. All right. So if we don't have any additional questions, again, just a reminder, here's my email address, ljones@sts.org. Just feel free to reach out to me if you have any questions. Also for help desk, please reach out to stsdb _ help desk at sts.org. That's, again, please reach out to the help desk for all harvest related questions and report related questions. Please, again, I can used to be able to typically help in the past with any report related questions, but please send all of those questions directly to the help desk so we can create a ticket for you, a help desk ticket. And then if it's something that I can assist with, the help desk will escalate your question onto me directly. If you have any questions about your STS participation agreements and invoicing, please email stsdb@sts.org and Jane and her team can assist you there. All right, so I'm not seeing any additional questions. So I think that's all the information I have, unless Ruth or Emily, Carol, Katie, anybody else had anything they wanted to share with the group? All right.
I don't have anything. Great webinar as always. Good job, Ruth. Good job, Katie. And
Thank
good job,
you.
Leanne.
Thanks, everyone. A little slow getting back into the swing of things. So sorry about that, guys. It's my first webinar since, back from vacation. So, well, I hope you guys all have a great new year. And we look forward to working with you all this year, upcoming 2025. And again, please reach out if you guys have any questions. We love your feedback. So please reach out and let us know how we can assist you better. Thanks, everyone. I hope you guys have a great rest of your day. And we'll see you soon. Thanks, everyone.
Bye.
Thanks, Leanne.
All right. Thanks, guys.